Now, it's a great pleasure to be here. I only arrived yesterday morning and I'm only here for 3 days, so it's a very long way to come. But I wouldn't have missed it for anything because I've had, as Phil said, a very long association with him, and it's been my great pleasure to be associated with him for so long. And it's fabulous products that you should look at and use really easily in the clinic, because patients can actually try them, and if they don't like them, that's fine, you know, but they can try it out. It's a good try before you buy approach. I'm thrilled that Terry has asked me to talk about this. I've been involved in doing some interesting research in the last 12 months. We've been collecting data from every patient that's been coming in the door, every knee patient, and this is some of the results, and it's been quite exciting. I thought I'd just show you this little picture of all the different types of ones and just show you how interesting it can be. This X-ray up here is an 83-year-old lady who has never ever had knee pain before, yet her patella is very laterally displaced. So often X-ray changes don't necessarily mean people are going to get symptoms, and this is what we have to look at. This one over here, 10-year-old girl, and you can see that her patella really shouldn't be sitting there. So different ages, different stages, different things going on. And I'd have to thank Howard very much for his great introduction on pain, because I thought we haven't even communicated, and you'll see in a minute that I'll be talking a little bit about what he's just talked about. And they should fit in very nicely about the whole chronic pain issue. So I was sitting there thinking, gosh, we did this quite well, and he started first. So he talked about the basic anatomy, and I'm going to be starting on this little slide here, which I thought fitted in quite well, and why people get pain and what we as therapists can do to help these people. And as it says here, pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. What makes us different to all the animals that we see out there, which is why some physios are going into animal physiotherapy, is it's a cortical experience. So the preconceived ideas, what you had in the past, that will really influence your feelings about pain, whereas animals, it's only the sort of owners of the animals that you're dealing with that are the problem. Now, what is very, very interesting, as Howard alluded to, pain can be quite difficult to treat because the causative factors are often quite remote from the site of the symptoms, and this is what I'll be talking to you about. So as I say, we did quite well in what we were talking with beforehand. Now, why do some people get it and not others? Some people choose the wrong parents. Their structure is poor. So would you like to raise your hand if you are unmarried or do not have a permanent spouse? Raise your hand. Okay, now those of you with your hands raised, keep them up, keep them up. Look around the room. Your potential sort of partner of the future might be here, because you're not going to go for love anymore, you're going to go for straight limbs. Then your kids might have a chance of not having a problem. So basically what we really, unfortunately, the genetics plays a big part in what we're going to see, what we're going to do, and some of us, you know, not only do we choose the wrong parents, but we also play the wrong sport, or maybe we don't play any at all. So it's really what we're doing with our bodies loading over time. So why do some people get pain and not others, even though they have chosen the wrong parents? Basically, they have poor dynamic stability. So we're really looking at how they control the system. So you may have ligamentous laxity. You may have an inability passively to control structures. But dynamically, you've got a lovely system of muscles that will come in and control what's going on. And that's what we're able to do, is help a patient control perhaps a dynamic problem, a static problem dynamically. So we really have to work on muscle control. Now, the biggest thing that we're looking at too is, why do people have problems? They operate outside their envelope of function. So you can do a one-off high load, pass the threshold there, or you can do several lower load activities, pass your threshold, and you will get pain. So what we're doing is really trying to restore the patient's envelope of function and make sure they're not working right at their end of range. So keep them in that envelope of function and hopefully increase their threshold, and then they'll be fine. So, in patellofemoral pain, where does the pain come from? Well, basically, if they have lateral pain, it has been found that you have increased tension in the lateral retinaculum, which will cause small nerve injury, and there will be a neuromatous type appearance in the lateral retinaculum. So they suspect that this is causing the pain. Medial pain, generally due to recurrent stretching of the medial retinaculum due to hypermobility or subluxation, dislocation of the patella. After a period of time, however, if it happens a lot, then that original pain that you get from disrupting the medial tissues will be gone, and those sort of people will roll over in bed and their patella will sublux, and it won't be too painful and they won't get too much swelling. However, their function will be extremely poor, and we'll talk about that in a moment. Posterior pain, deep pain. Now, what has been said is it's probable articular cartilage damage. Now, interestingly enough, as Howard just said, the articular cartilage has no nerve fibres. So we have to wonder whether really, in fact, chondromalacia actually does cause pain. And I'll be questioning this rationale in a moment. Inferior pain. And these sort of people are quite different with their type of pain. They have pain on prolonged standing, so they're quite atypical for patellofemoral pain patients who have pain with prolonged sitting. And what is the structure in question here? It's the fat pad, the wonderful fat pad. Now, if I just go for a moment and have a look at OA knees, because the fat pad is something I'm going to talk about a bit more in a moment, as it is probably the under-recognised, undervalued structure in the knee that is causing symptoms. Now, you can see from this lovely OA knee here, one of my patients, the severity of knee pain in OA ranges quite widely. You can have people who have severe OA changes on X-ray with no pain. You can have people who have very minimal change on X-ray with excruciating pain. So you cannot tell from the Kellgren-Lawrence scale of change on X-ray how disabled that person is going to be as far as their function is concerned. So if you look at the studies on osteoarthritis of the knee pain severity can be associated with subarticular bone attrition, bone marrow lesions, global bone marrow edema pattern, synovitis, effusion, meniscal tears. But for bone marrow lesions to actually cause pain, you need bone attrition. WOMAC scores, there's no correlation with the Kellgren-Lawrence scale and the extent of findings of MR imaging. The only cartilage lesions on MRI associated with clinical findings or WOMAC scale is if you actually have the bone attrition as well. So you need bone attrition, and that will correlate to some extent to the WOMAC scale. Osteophytes, also not associated with the presence of pain or the severity of pain. So you can see with osteoarthritis of the knee, there's a wide sort of ranging group of people. They're not homogenous, and they're going to be quite different. Some can't get out of a chair, some can still run. Basically, another study by Hill found that if cartilage loss was greater than 50% and the synovitis was not associated with the cartilage loss in the tibio or patellofemoral compartments, then perhaps this was more related to why people were getting pain. So synovitis, that was probably why they were getting their pain with their osteoarthritis. So we go back to the fat pad for a moment, because we've been looking at this quite extensively as far as pain is concerned in the patellofemoral joint, but now as far as osteoarthritic pain is concerned, it is one of the most pain-sensitive structures in the knee. 78% of college athletes that were diagnosed with patellar tendinosis, and you can see here, this is a patellar tendinosis image here with this athlete, also had changes on uptake in their fat pad, which you see just here, on MRI. So the thing is that the patellar tendinopathies also have fat pad changes. Is this why you're getting pain in patellar tendinopathy? MRI of the fat pad, you will find that the abnormalities that they see are commonly the consequence of trauma and degeneration. The commonest trauma to the fat pad is an arthroscopy. So if you want the patient to get more pain, send them off for an arthroscopy. So you can see why a lot of patients, they've had a simple meniscectomy, they've had an ACL reconstruction, lo and behold, what happens? Increased pain. Now it's a different pain, failing to get better because their fat pad has been further irritated. There's increased sensory innervation after primary arthroscopy in the fat pad. So you get increased sympathetic innervation in the fat pad after arthroscopy. So how do we know that the fat pad's so pain sensitive? Well, you have to do a study on asymptomatics. So what we did in this particular study is we injected the fat pad with salty water of asymptomatic individuals. If you're going to have that study done on people, you have to have it also done on yourself. Interesting study. So I had my fat pad injected, and the first knee they injected, they missed my fat pad because I'm getting the scaling done, and they go, 1 to 10. I go, oh, it's about a 1, a 2, a piece of cake, really. They missed my fat pad. My other knee that they did, it was nasty. And it's interesting because you don't want to be a wuss. So and it's interesting scaling pain. So because you can't remember how bad pain was. Now I've fractured my femur and had 2 children. So I'm thinking, I'm sure it's not as bad as the fractured femur. That was pretty bad, but you can't remember how bad that was. The 2 children, no, that was pretty bad, but at least I got a baby at the end. So from 1 to 10, how bad was it? It was a 7. It was a 7. It was excruciatingly nasty pain. Lasted for 10 minutes. I thought, why am I doing this study? This is really terrible. So when you inject the fat pad in asymptomatic individuals, you will get nasty pain. And we're talking about 0.2 mils. It's not a lot. Didn't cause any swelling. Potent source of pain. So the people that got only the 3, I wondered whether they missed their fat pad. But you can see some people called it a 10. Maybe they were actually less wussy than I was. But the interesting thing about the pain distribution was it was not just localised to the infrapatellar region. Everybody also got sort of retropatellar pain. 2 people got medial thigh pain. 1 person got groin pain from injecting their fat pad. Now, I'm sure if you have a patient coming in with groin pain, you don't go, oh, I think that's coming from your fat pad. But if you think about it, the infrapatellar branch of the saphenous nerve innervates and comes through the fat pad. So where does the saphenous nerve come from? Very interesting. So it is a highly, highly innervated structure. And it's extensive. It really is an extensive structure. What does it do? Oh, interesting. Well, first of all, it's very important for stabilising the patella and the extremes of knee motion. So in less than 20 degrees of knee flexion, so when you're in that final range of knee extension, the fat pad is actually improving the knee biomechanics. Past 100 degrees of knee flexion, it's also improving the knee biomechanics, but also not only the patella, but the tibiofemoral joint. So as you extend the knee, it actually improves tibial external rotation by 3 degrees. So if you take the fat pad out, you get a change in the biomechanics of the knee. So what do orthopaedic surgeons think? Oh, fat pad, pain, oh, I know, let's do what we should do is just take it out. What a good idea. Very good idea to take it out. It's a good solution. Well, let me show you an MRI of someone after a fat pad. So this is one before, over here, and this is after. Look at all the scar tissue here where the fat pad's been taken out. And guess what? It still causes pain. What a surprise. So the very important thing is to never underestimate how important the fat pad is in actually being part of the whole knee mechanism and being a potent source of pain. Animal models. So pigs also have fat pads. 68% of the pig's fat pad is type 1 collagen. Type 1 collagen is able to resist tensile forces, okay? So it's a really important structure to resist tensile stress. The inner layer contains less water and will help diminish compressive loads. They use pigs' spines to see what our spines do, so it seems fair that we use the pig's fat pad to see what our fat pads do. If they inject a rat with a monoiodoacetate, which is an OA inflammatory model, 21 days of weight-bearing asymmetry caused marked inflammatory changes in the fat pad. So they felt that this may be what is contributing to the pain in early stages of osteoarthritis. So, fat pad irritation, what is it? Poorly described, underdiagnosed. So everybody in this room, hopefully you'll see that it's an important thing to recognise. Usually you'll see it acutely with a rapid extension of the knee, as you can see with this game here called cricket, which most of us in these countries know. For our American friends, it's a game that you play for 5 days and nobody has a winner. But this rapid extension here of the knee, that can cause a fat pad irritation. The swimmer, tumble turn off the wall, pushing out. Freestyle swimming, that will often make the pain worse. So all of those things can contribute to fat pad irritation. So think of the kicking motion, the extension motion, the rapid activity will cause a sudden onset, but it's often confused with patellar tendinopathy. If you have a swimmer who has inferior patellar pain, they can't have patellar tendinopathy unless they're doing strange cross-training, because you need eccentric loading to stir up the patellar tendon to get a patellar tendinopathy. So you need to have increased jumping or running downhill. So really listen to the patient's history. So with the fat pad irritation, the knees are hyperextended or locked back in standing. The inferior pole will often be embedded in the underlying tissues, and they will have focal tenderness on the inferior pole, and they will be quite puffy. They're worse with extension manoeuvres. Guess what? If you give them a straight leg raise program, lovely. You'll exacerbate their symptoms and confirm your diagnosis. Do not send them home doing straight leg raises unless you want to confirm your diagnosis. Okay. Patellar tendinopathy, just to remind you, eccentric loading. All right. So this particular person I showed a bit earlier with the patellar tendon problem, this is after taping, and you can see the patellar tendon looks completely different pre and post taping. So it looks thicker and it looks more bulgy, but the interesting thing is the fat pad bulging out. I'll just... Now the study that I'm doing at the moment, this is only 65 patients. We've currently got 320 in the study. And we looked at everybody aged from 14 to 79, so we've got a big wide range, and they've had a whole bunch of problems that were diagnosed. So they could have had osteoarthritis of the knee, dislocating patellas, ACL injuries. We looked at every knee pain patient coming in. We did a VAS. We also looked at a Kajala scale and a Womack scale, and then we were measuring the fat pad with a tape measure, which was the most reliable, interestingly enough, and we've done some MRI scans pre and post tape, pre and post treatment. So we were measuring fat pad size, we were looking at extension overpressure, trying to reproduce symptoms, and looking at the squish test, which I'll show you tomorrow. So here we're doing the lovely measurement with the tape measure. Frequency of area of pain reported, 46% had inferior patellar pain, 43% medial, 23% retropatellar pain, 20% lateral pain. So 53% of the retropatellar pains also complained of inferior or medial pain. 61% of the patients complained of pain doing a quadriceps contraction, ranging from 1 to 8 on the VAS. 45% of subjects experienced pain on extension overpressure, ranging from 1 to 9 on the VAS. So if you want to make them worse, give them straight leg raises as a home exercise program, particularly if you get them to do a quad set. So just remember how important that is. The size of the fat pad was 10, actually should be centimetres on the unaffected side, and 8.5 centimetres on the unaffected side. So 10 on the affected and 8.5 on the... So the results were variable as far as MRI is concerned. The diagnoses, ACL injuries, meniscal tears, tricompartmental OA, patellar tendinopathy, patellar dislocation, medial femoral softening, CMP. And the patterns on the MRI signal, okay, for example, this is a dislocation, and you can see, I'll just do the big one here. So you can see here where it's actually, you get a contusion, the fat pad is involved, they've got a high-sitting patella, lateralised tibial tubercle, bone contusion, and this is a 15-year-old boy who had a dislocation with the fat pad being significantly involved. So we need to tape for the acute dislocation, which I'll be showing you tomorrow. We need to shorten the retinacular tissues to make sure that they heal properly, and we need to unload the fat pad itself. Patellofemoral impingement, which we see on this one here, patellofemoral impingement just here in this white area here. So the whiteness on the MRI indicates the increase in uptake on the fat pad. Hoffer's disease, you can see this marked amount of whiteness. Okay, that's chronic sort of fat pad involvement. And you can see here in this 53-year-old woman, she fell on her knee, and again, this thickening of the fat pad. Tibiofemoral impingement, and this is the one which we have just discovered, really. This area here at the intercondylar notch is where we think a lot of tibiofemoral osteoarthritics get their pain from. As you get a narrowing of the joint space, you'll get an impingement of the fat pad, and that's why you get the flare-up of osteoarthritic knee pain. Again, treatment will settle it down. Scarring after endoscopic surgery here, and the final one, infrapatellar plica syndrome. So we'll talk about taping for subluxing patella. And I'll just very quickly talk about the effect of tape on the study that we've been doing. But what we've found is the tape will increase the fat pad depth. You get a change in the inferior patellar shift, an increase in patellar tilt, so you get a change in the load of the patella. So what we've been measuring is this volume through here, and you can see it looks much bigger there than here, and we've changed the orientation of the patella. Same. What happens after treatment, interestingly enough, is the patella rolled into slight varus alignment in all cases, whether they were tibiofemoral osteoarthritis or patellofemoral osteoarthritis, and we're talking about the arthritic group. And what we've concluded is that that indicates improved resting tone of the VMO. So the quadriceps is now working better in these individuals after treatment. Okay, I'll just... So why do people have a problem? Is there a motor control issue, or is it because they have pain? And basically what we've found is that there is, in these individuals, a motor control issue. So is pain causing the timing delay, or is timing delay causing the pain? We've given patients pain, found that that changes the amount of activity in the VMO and the VL. So significantly, if you have pain, your muscle turns off. All right? But equally, if you have pain, you also develop a thing called fear of pain. So we wanted to test what would happen if someone actually got pain given to them, and these are asymptomatic individuals, and what we did in this case is we gave them an electric shock across their knee. So again, the asymptomatic individuals, we turned on electric shock till we sorted out that was painful or not, and got them to decide, oh yes, that's my pain threshold, yes, that's painful. Then intermittently and randomly, we gave them an electric shock as they were walking and as they were walking up and down stairs. First of all, your gait pattern changes because you're expecting pain to happen at any stage, so you sort of have this funny walk. But the interesting thing is that fear of pain will turn off the VMO. Doesn't turn off the VL, but it turns off the VMO. So if someone has pain and thinks, oh, those stairs over there, gosh, you know, I don't know whether I can go up and down those because they're painful, it will turn the VMO off. So then they go up and down the stairs, and guess what? It is painful, so then it reinforces their pain belief. So it's really, really important that we do something to change their fear of pain. Equally, if they're anxious, it will affect the amount of cortisol going through the body, and that will also increase their pain. So pain, fear of pain, all of those things we have to deal with. Negative self-talk also affects a person's perception of pain. So those are the people that go, oh, I hate my knee, I hate my knee. And you have to tell them every night, you've got to say, I love my knee. My knee is great. It helps me get from A to B. Because the more they think, I hate my knee, it reinforces it. They're the ones that suck all the energy out of you, you know, in the day. The half-full people. I've got the broken fingernail. Okay? The other thing is if they hate their job, it will also affect their perception of pain. So if they hate their job and they don't feel well respected at work, again, their pain will be worse. So there's a whole bunch of other things contributing to all that. So how can we break the pain cycle? Got to explain to the patient what's going on, help them understand what's happening, talk to them about fear of pain. Exactly what Howard was saying. If you can actually break that cycle, it'll make a huge difference to them, and then you can start doing something. So you have to be able to unload their pain. Equally, turning off their pain with various aspects of treating sympathetic dystrophy, so you can rub it and do all sorts of things. Placebo effect, beautiful, use it. Don't worry about it. Doesn't matter if you know you think it's placebo, because it works. If you're nice to the patient, they will get better. They will get more better if we're a bit more specific in what we do, but it is very important that we should utilise the placebo effect. That's why they've found that, you know, colourful medication is much more effective than plain white ones. That's why people that are very nice to patients actually, you know, she was such a nice person, usually do really well, particularly for people who are lonely, living at home, and they need contact with humans. But what I'm going to talk to you about is unloading painful structures, particularly the fat pad. If you can unload it, you get rid of fear of pain, and they do really well. What does tape actually do? So we do know that tape does reduce pain, reduces fear of pain, increases quadriceps muscle torque, increases tolerance to knee joint loading, alters the patella position. And we actually know that even though I've got the controversial, we're actually finding more and more evidence now that we get a change in pressure distribution, which is probably what an orthotic does, because it's small movement. But the most important thing is this reducing pain, fear of pain, and improving muscle firing patterns. Decreasing swelling is very important. I just thought I'd put up electric soda. I don't know whether you can get it in this country. Sensational. It's wonderful. Electric soda is water softener. It's washing soda. So you get it at in the supermarket, in the laundry section, and it comes in crystals, and you put it in a tea towel or a pillowcase, or wrap it in some old tights, wrap it around the knee overnight, and it will draw the fluid out. Draws the fluid out. Sensational. Why does it work? Osmosis. Fantastic. It's wonderful. Okay. Restores, this, you're giving me the movement here that I should be winding up, Terry. Restore the dynamic balance of the quadriceps muscle. So we want to improve the position of the patella relative to the femur. So we want to make sure that we don't do straight leg raises. We must make sure we're doing dynamic training in weight bearing. Don't do straight leg raises. It will increase the fat pad irritation. And we have actually done a double-blind randomised placebo-controlled clinical trial to show that physiotherapy treatment is very effective at improving VMO timing, whereas placebo treatment, even though the patient felt a little tiny bit better, was actually not very effective in improving the timing. So the physiotherapy patients actually felt a lot better, but the placebo patients did a little bit better. What did the placebo patients get? Detuned ultrasound. So if your ultrasound machine doesn't work, it doesn't matter because they'll feel better anyway. And being nice to the patient and that sort of thing. We may have to down-train the VL. So as we saw in the foot, You've got to downtrain or change the orientation of the agonist-antagonist, the same sort of thing in the knee. If the VL is overactive, the VMO will never turn on, so we might have to do something to change that. And the patient goes, I have been at the gym, I've been working really hard, and I get more and more knee pain. Why? VL's getting stronger and stronger, VMO's staying weak. Remember, the strong get stronger, the weak stay weak. It's a bit like the rich get richer and the poor stay poor, you know. Same sort of phenomenon. We've got to just change that balance so the VMO starts working better. We want to improve anterior hip flexibility, which I'll show tomorrow. We may have to change what the hip is doing, which I'll also show later on today. And we will want to train the gluteals, which I'll talk about in more detail later on. We also need to look at what's going on distally at the feet. We might have to mobilise the subtalar joint. We may have to mobilise the first ray. We may have to give the patient some orthotics, rigid or hard. I quite like soft orthotics. And we could even tape the foot. What do we know about evidence of orthotics? Reduces patellofemoral pain. Basically, what you'll find is that it will change the EMG activity of the muscles in the foot. It also decreases fatigue of foot musculature, the use of an orthotic. The most important thing about an orthotic, though, is comfort. If it's not comfortable, they won't wear it. So comfort is the most important thing. And custom orthotics, as well as off-the-shelf orthotics, actually work equally well, which is quite interesting in the studies. So you have to realise that, you know, sometimes you don't have to be biomechanically correct, just take them out of end of range. And this one is from a 1912 Lancet, so they've had arch supports, if you like, and foot things for a very long time. And we need to give patient simple strategies to change what is going on in their bodies. Give them very simple, effective things. So, I want everybody to stand up. I want you all to turn that way, so to your right. And I want you to get sort of, get close, sort of closer to each other, so closer and closer. Close, close, close. Everybody get close. All right. Now, while you're nice and close there, I want you to palpate the gluteals of the person in front of you. Palpate the gluteals. Okay, now while you're palpating there, now that you've got your big thrill of the day, the semi-next one, I just want you all to stand in a sloppy old position that you all stand at, just resting. Feel the gluteals. You're actually, there for feeling. This is a scientific experiment here. Now you're going to stand on the other leg and feel the gluteals, okay? Now, I want you to all turn your left foot out so it's at 45 degrees. Put your right foot so it's past the instep of the left. And it's also at 45 degrees. And your legs must touch. Legs must touch. Legs must. Some of you won't be able to do it if you have a big degree of tibial verum. But legs touching. Now feel the gluteals. This is the secret. Ballet third position, if anybody has ever seen it. This is the secret. The secret to what? Low back pain, knee pain. This is the cocktail standing position. You are working, you have now engaged your gluteals, and if you want to, you can bring the arms around the front and you'll be able to feel the person in front. Just feel them very quickly. This is pre-morning tea. You're going to feel how much their abdominals are working. Without even trying, we have now activated transversus abdominis. Don't tell anybody in Queensland, though. Is anybody from Queensland here? And also getting the gluteals working. This is the secret. Simple strategies are what people need, and they will love you if you tell them that. Okay. If you tell them about that position, they tell their friends and their friends' friends, it's the position you stand in when you're watching the kids on the sideline playing football. It will stop back pain and knee pain because you self-support. It is sensational. Keeps you upright. Very hard to slump in this position. Okay, it's the secret. So that's all actually. I'll finish with a bang.
A question about the training up the VMO and bulking that up. This is a long time knowledge, and it may be wrong now, so please correct me. But we used to work with some sports injury patients, and it was to a straight leg static exercise to bulk up the VMO. Often used to get the kids or whoever had it to just under the desk at school. Just
and turn their leg and go in. And, yeah.
The VMO.
Do you know there is no evidence? In fact, the studies have done to show that internal or external rotation makes no difference in getting a VMO in straight leg raise. The main muscle that you work in your straight leg raise is actually your rectus femoris, and if you have very poor abdominal control, then you'll actually get low back pain as you do it. So the external or internal rotation doesn't change it, and there have been quite good studies to show that the rotation doesn't change. Stendosser is one that actually looked at all that and found that if you want to get more vasty activity, you need to do closed kinetic chain work rather than open kinetic chain work. I don't know, straight leg raises, I've decided, it's a bit like mother's milk. Universally should be good for everybody. And I think it's viral, straight leg raises. You know what that means? It came in, and because it's viral, it's going to be hard to eradicate. It came in the 1940s with DeLorme boots. You know, they developed a boot in the US that weighed 100 million tonne that must have actually, I don't know, they were doing it for post-war, I have no idea. But it must have stirred up people's backs, is all I can say, which is probably why there's a back pain epidemic, because they were all on DeLorme boots beforehand. But what happened was orthopaedic surgeons decided that that was a good indication of quadriceps function. So person has knee replacement, they go in, oh, can the person do a straight leg raise? Here's the person with this painful knee, barely able to activate their quads, and they're going like this trying to do a straight leg raise, and it then aggravates their back. It's obscene. If they really need to do a straight leg raise, to go back to pass the test for the doctor, I show patients how to cheat, how to do a straight leg raise without actually hurting their quad.
Just to correct what I was saying, it wasn't actually to lift the leg, it was just to
yeah, even to tighten. And the wonderful thing about even the tightening of it, which is why I was talking about the fat pad, is 68% of the patients that we saw coming in the door, regardless of their diagnosis, a quad set made their pain worse. 68%, that's high. They could have had an ACL injury, there could have been OA, there could have been a dislocator. So any knee pathology coming in, 68% of them experienced pain when they did a quad set. So, you know, it's probably okay in an asymptomatic, you know, but I wouldn't do it on a knee pain patient.
The other thing I remember clearly was to avoid squats, you know, people doing squats.
Yeah, and that's true too. What you need to work on, and I brushed over how we're going to train VMO, but basically you need to make sure it's working in the first 30 degrees. That's where, and this is where it's all sort of the straight leg or short arc quads came in. That 30 degrees is before the patella actually lodges into the trochlea. So the soft tissue is very important for really positioning it. After that 30 degrees, in most people, it's too late. So the patella's already in the wrong position and the VMO won't actually change it a great deal. So it's too late. In the people with patella alta, then, you know, their patella is miles away from the trochlea, so, you know, they need really good quads because they need control, and their patella is very unstable. And the people with a very high angling orientation of their vastus medialis, because I don't think they have a VMO, into their patella, they have great problems as well. So they're the ones that have been described as having wet soap on slippery glass. So and that's like the lady I showed you. She was a good example. But you can do things for them and you can actually help them. So you shouldn't give up. I mean, my message to all of you out there is we are their saviours. We shouldn't give up on them. They need us. They need us, you know, to do a whole lower extremity examination and really help them, because there are lots of things we can do. If they end up in the hands of the surgeon, oof, you know, because the surgery is not great. This is a soft tissue problem, and the surgeons don't really know where the pain comes from. And when they took out the fat pad because they thought that's where the pain came from, saw what happened. You can't take something out. They used to take the patellas out because that was the source of the pain. Fortunately, they've moved on from that, you know. But patelectomy was relatively common in the 60s, I think. It's good, isn't it?